In our general school system, 10 to 20% of our children have learning difficulties. That's a really high number. And I think if you look in the literature on the prevalence of true learning disabilities based on developmental issues, like if somebody has a true developmental delay, it's a lot lower number than that. So there's some disconnect going on there. So I think that was how I got into doing vision therapy, was primarily for learning difficulties. And then over time, we started to realize that the kids that didn't have any developmental factors, a lot of them had histories of pediatric concussions. So we were kind of sitting back here going, are we really dealing with a learning difficulty case, or is this just a pediatric concussion? Because the visual system is so dominant, we have to be very, very careful to assess it in detail and not just assume, well, the patient sees 20/20, therefore they're fine. There are about 15 to 16 other visual skills that are required other than 20/20 for somebody to be able to function properly. For example, when I read, I have to converge and I have to move my eyes from side to side while I'm converged. That is nothing to do with me staring at 20 feet reading a letter. A routine eye exam is perfectly fine for a routine case. But as soon as you get a learning difficulty case or a concussion case, really it's a different type of case, and you still have to do all that stuff, but there's a lot of stuff you have to do in addition to that. The other thing that we like to use is, which really looks at eye movements also, is a visograph, which is it's a goggle, and you put it on. There's 4 infrared cameras on the inside of the goggle. The person reads material, and the cameras actually record what the person's eyes are doing on the page. So you can see their eye movements in real time, which is really revealing, because it's very hard to, for example, in the concussion world, how do we know if somebody's truly concussed? Are they faking it or are they concussed? It's very hard to fake eye movements. It's very hard to fake how you read. The other test that we tend to use a lot is our test of ocular motor function. So for example, just basic convergence. I'm moving my eyes towards my nose. It's very interesting that if you understand how to use your periphery, you can greatly increase your control of your eyes. And one of the biggest things in concussion is patients basically lose the ability to control their eyes. People think it's a muscle problem, but if somebody, for example, has a convergence insufficiency, which is very common post-concussion, if I close one eye and I get the patient to look in every position, I can move my eye in every position monocularly. There's no restrictions. If I then get that patient to go binocular, they have trouble pulling both eyes in together. So my number one question is, how is that a muscle problem? If they can do it monocularly, but they can't do it binocularly, that can't be a muscle problem. It's got to be a brain issue. The brain doesn't understand how to control the system. Prisms and lenses, from our perspective, are the most valuable tool that we have. So if somebody comes to me and they're messed up and they say, if I look at the floor and the floor looks tilted to me, and I have to tilt my body to make the floor look flat, I can take a prism and I can make the floor look this way so that they'll come back to this. So I can actually manipulate the entire gait of the patient with a yoked prism, whereas a non-yoked prism is used for taking a patient who's double and putting the 2 images back together. The other thing that's often brought up is an overlap between ADHD and binocular vision symptoms. We've got to be careful because it could be one, it could be the other, but we do know that 5 out of the 9 symptoms of ADHD overlap with the symptoms of binocular vision dysfunction. So we've got to be careful about not assuming a child is inattentive and putting them on a medication incorrectly, rather than saying, well, wait a minute, maybe this kid can't control their eyes properly and they're having trouble attending because of the binocular vision issue. So you can't really rule out one unless you test for the other. But I would say more often than not, in kids that have reading-based issues, they typically have a fairly high degree of ocular motor dysfunction. And in concussion populations, I would say it's 80 to 90% plus of these patients. I mean, there's a reason why a lot of them are light sensitive. They can't handle peripheral motion in crowds. They have trouble with computer screens. If you say to most concussion patients, how do you feel when you scroll on a computer? How does that scrolling on the screen make you feel? They will go, oh, it makes me feel terrible. I hate to look at it. We tested 250 varsity athletes at baseline. Anywhere between 12 to 18% of these supposedly healthy athletes at baseline are failing ocular motor testing at baseline. So you could say, 1 in 10 to 1 in 5, potentially. If we say 1 in 5, 1 in 5 athletes playing sports do not have a very well-functioning binocular vision system. So if they then go on to have a concussion, it probably explains why you often see different patterns of recovery in 2 people that have had a very similar injury, very similar sport, yet they have the injury and they both recover completely differently. When I deal with a patient who's had a concussion, you're not just dealing with the concussion, you're dealing with the concussion plus all the pre-existing history. I firmly believe that if you're dealing with a child who has learning issues or a history of concussion, that more than a screening, I think a full ocular motor assessment should be done. But I think if you have kids that are playing sports, for example, most sports, hockey, soccer, lacrosse, these sports have risks of concussions. So to me, it is common sense to have baseline data in these people. And I think there's been some debate out there about whether, is baseline testing a waste of time? I think it is a waste of time if it's poor testing and it's done on the general population. But I think it's very, very useful if it's done on a targeted population that are at a higher risk because they play a certain sport, and also the proper tests are done.